Welcome to the Everyday Epigenetics, raw, real, relatable podcast. We're your hosts, Susan Robbins, certified epigenetic human performance coach,
and Kate King, licensed psychotherapist, board-certified art therapist, and award-winning author. Together, we bring two perspectives, two styles, and one shared passion for epigenetics.
On this podcast, we delve into topics such as environment, nutrition, fitness, mindset, social dynamics, and trauma as they pertain to epigenetic expression in a way that's relatable to everyone.
We recognize that everyone's needs are unique. There are no one-size-fits-all solutions for your mind, body, and heart. The true magic lies within you.
So if you're ready to create a radiant life through epigenetics and reclaim your authentic self, then buckle up. Here we go.
Imagine that all of these different insults that your immune system is dealing with, it's that, I don't know if it's a magician or what you would call the person who spins plates, and they can spin plates on like pool cubes, and they can spin 10 or so plates and so on, go back and forth, spinning your plates. That's what your immune system is doing. It's spinning like all of us. All of our immune systems are spinning 10 plates at least, right? At least 10 plates. So you think, okay, how many can we take before it all breaks down? So for many people, the end plate that brings everything down is gadolinium.
Welcome to the Everyday Epigenetics, raw, real, relatable podcast. We are your hosts. I'm Susan Robbins, and I'm here with the lovely
Kate King. And today we have a very special guest that I'll let Susan introduce to you because this is a topic that is very personal to her and very meaningful.
Thank you, my friend. So this one might get me a little emotional because I literally went through a season of hell in 2018. And I've talked about it in my very, very first podcast that I did last year to introduce that I had something called Gadolinium Deposition Disease. Gadolinium is a very toxic heavy metal, and it's used in MRI contrast injections. And I know there's different types of the gadoliniums, but I am so honored to have on today to talk about this topic of gadolinium deposition disease, or GDD, with Dr. Richard Semelka. I came across him just browsing through some podcasts a few weeks ago, and it said gadolinium. And I said, you've got to be kidding me. And so I reached out to him and I told him about my story, which I'm going to relay here in just a second, that I had gone through this. And his story, it just made me feel so validated, because you'll hear how I wasn't validated throughout this incident that I dealt with. And how many people are out there getting MRIs with contrast injections every day? The doctors are always saying, you need to get an MRI with contrast. And we're like little rats to the lab. Okay, inject me with whatever, not knowing that there are things that can put us at increased risk for this condition, so much of which I didn't know and had, and that it's kind of like a Russian roulette. I always say, how many bullets do you want to go through? And because the more you have of these, the more risk it can put you at. So Dr. Semelka's career, he's shown to be number 10 in MRI, number 12 in medical imaging worldwide by Scholar GPS. He's written six editions of textbooks on MRI of the abdomen and pelvis, 5 editions of a textbook on MR physics, a textbook on quality improvement in radiology, and over 380 peer-reviewed articles, including the broadest range of subjects on safety issues in radiology. Most recently, he's described the entity Gadolinium Deposition Disease, on which he's written more than 16 articles. He's lectured around the world on topics in radiology over a 35-year career. He presently is devoting his medical career to treating individuals with gadolinium deposition disease. We'll just say GDD from here, so we have to draw it out, and other metal toxicities. He's the president of a nonprofit, GADTRAC, that's GADTTRAC, an organization devoted to helping sufferers with gadolinium and other heavy metal toxicity. Welcome to our program, Dr. Semelka.
Well, thank you for having me.
So we talked about it, and Dr. Semelka thought it best for me to tell my story first, because I think there's maybe people out there that resonate with what I've been through if you haven't already heard it. So I'll try to keep it as brief as possible, but I think it's pretty impactful on what this GDD can actually do to the body and the mind as you're going through it. So back in 2018, I was having I'm an avid CrossFitter, and I was having issues with my hip, a lot of pain going on. Went to a new orthopedic because my usual sports medicine guy was not covered by my new insurance. And I thought, I'll go to the orthopedic. And he looks at it and he said, I think you have a hip labral tear, but the only way to tell is we do an MRI with contrast. And I said, I don't want contrast. I had a year prior found out that I had Lyme disease, contracted it twice, and it took 11 years to diagnose me. And I didn't know my genetics. I didn't know anything back then other than I felt horrible. And it took me a year to get it into remission. I went through pretty good hell then. A lot of joint, brain, cardiac. It was just a nightmare. So come to this, I said, no, I have Lyme. I just got it in remission. I don't want to put anything else in my body. I don't want to touch anything. And he said, Susan, it's safe. And I was in Montana at the time. And he said, there's only one guy here. If it's a labral tear, you're going to need surgery. And there's one guy in Bozeman that does it. And he will require an MRI with contrast. So you're going to get charged twice. So the almighty dollar, I said, fine, I'll do it. The day of the MRI, I called them because I started having second thoughts. I said, I don't want contrast. Something just said to me, don't do it. And they said, Susan, I'm telling you, this is so safe. We use it on little kids. I guess that's supposed to make me feel safer. And at the time, I guess it did. And they said, you don't have kidney disease. You'll pee it out right away. So they talked me into it. I went in there, super painful actually, to get this contrast injection. And he said, it'll wear off. You'll be fine. You'll be fine in an hour. And I wasn't. 8 hours later, because I remember distinctly looking at my watch, that was 8 hours. The pain in my right leg. Now, this was supposed to go into the hip labrum, into that joint. The pain was so bad that I couldn't walk on that leg. What the heck? This isn't supposed to happen. And they told me this was really a painless kind of thing. And I had, boy, what was it? 6 years prior, 4 to 6 years prior, I had another contrast injection for an MRI in my calf. I had no issues at that time, none. So I didn't even think about this. So cut to, I can't sleep that night. The pain is so bad. And it was like, what is happening? It was just like a burning. And then this deep, deep pain. And I am the injury queen. I've never experienced pain like this in my life. I couldn't sleep. I'm trying to take, and I don't take things, and I'm trying to take everything I could in the Tylenol, ibuprofen, nothing was helping it. So I called the orthopedic the next day and I said, something's not right. No, it was 2 days I waited, and it kept getting worse. And I called the orthopedic and they said, come back in. And I went in, and now it was 3 or 4 days. And he said, Susan, it's just Lyme disease. You're just inflamed. And I said, I've been dealing with Lyme for apparently 11 years. I know the difference. This is not Lyme. This is a pain that I can't sleep. I can't stand. I can't sit. And I couldn't get it was my right leg. I couldn't get my right leg directly under me. I had to push it out to the side. So I was walking with this crazy limp, and that was the only way it was somewhat comfortable. I couldn't stand. I couldn't sit, sleep, nothing. And he said, I'm telling you, it's the Lyme. You're going to be fine. Give it another week. You'll be fine. I'm going, well, I'm hoping I can sleep in a week. Sends me home with nothing. The contrast I got on a Monday. By Friday, it's Friday night, and I'm having twitching going on in my quad. Now it feels like something is inside my bone, but it's all the way down it was all the way down the right leg. My skin feels like it's on fire. And now it's in my left leg. And this is all the way down to the foot. I'm like, I can't deal. Something isn't right. So I'm holding onto my bed, like screaming, please stop. And I live alone. And I'm like, please stop. I can't deal with this pain. So at about 4 a.m., I drive myself to the ER because I was that desperate. And I'm there and I'm crying. And they said, all right, well, just give us a few minutes. I'm like, please get me in there. I can't stand, because even trying to stand, even with my leg not under me, was excruciating. And I said, please get me back there. They finally got me back there and they're like, all right, lay down. I'm like, I can't lay. I can't sit. Just give me something. And so they give me shots of Toradol. I've never had that in my life. And so they come back, how are you feeling? I'm like, there's no change. There's absolutely no change. I was there for a couple of hours and they gave me all the Toradol they could give me before it would become toxic. And they said, so you are feeling nothing. I said, I can't handle this pain. What is it? And the doctor was visiting. He was actually from Mexico and he had a really heavy accent. And he said, I think it's gadolinium. And I'm like, "Gada what?" And he said, gadolinium from the MRI. And I'm going, I don't understand what you're talking about. So I go home and I start looking and they gave me a muscle relaxer, knocked me out for 1 hour. And then I was up in horrible pain again. And like I said, it kept getting worse. I was recording videos because also my skin on my legs in just those few days started to go crepe. And I don't know, and I'm going to ask you about that as we get into it, Dr. Semelka, if that's a symptom. Because sure, I had some cellulite, but it literally went crepe on my legs. And we were videoing this, my friend that came over, that I couldn't stand on this leg. And that my quality of life by that time was like a week. I didn't know who I was because I couldn't even sleep. Called the orthopedic again, and he said, give it another week. Now it's going on 2.5 weeks. And I called my doctor and told her about the gadolinium, what this doctor had said in the ER. And she said, you might have gadolinium poisoning. And so she said, let's do the doctor's data test, metal test with urine, 24-hour. Did that, sent it in. What was going to be a while till we got the test back. And so she's like, hang in there. First of all, you need to get off that leg because now that leg, picture me trying to walk with my right leg straight out to the side. I couldn't drive. I couldn't work. The lack of sleep was crushing me because that was when it was super painful. And I'd literally sit there watching my quad just going boom, boom, boom. Then, I couldn't even cook. I had friends going to the store for me and I said, I'm thinking detox. And I said, just get me bags of organic kale, frozen kale. I can put that in the microwave. That'll help me detox. Organic broccoli. That was what was in my head. Not knowing the dangers of the kale with thallium. So I'm eating like a bag of this stuff every day because that's all I could do. Eating this, trying to eat eggs, anything quick because I couldn't, like it hurt to do anything. It's just a pain, an inside pain that just doesn't stop. And all of a sudden my hair is coming out in clumps. I'm getting these red spots on me that were itching and I'm like, what? There's something not right. Went back to the orthopedic. This is why we're waiting on the labs. He told me that I was literally nuts. I said, I'm having twitching going on. And he said, I know what's wrong with you, Susan. And I said, what? Please help me. And he slides up on his little stool in front of me and he's like, you just have anxiety. And I about flipped out on him. I said, I take care of myself. I don't have anxiety. I am in pain that you can't see. I don't sleep. I can't do anything. I have no quality of life. And if I didn't have this cat who is like my best friend, if I didn't have him taking care of me, I would be going to Oregon to try to get assisted suicide because I can't live like this. That's how bad it was. And I'm someone who's always loved life. And I was like, I'm ready to check out. And he told me, he said, that's just catastrophic thinking. He was so rude. And I'm like, I'm going crazy. My doctor, my naturopath was like, you need to get off that leg, get on crutches. And when I went in there with crutches, he told me I was crazy. So 3 weeks later, 3 to 4 weeks later, I decided to get in my car and go see my old sports medicine guy. Took the MRI to him. And when the MRI came back, it actually did show I had a very large tear in the labrum and also a small one. His name is Buzz Walton. I'm going to give him a shout out. This is what gets me emotional. I went up to Buzz and I said, tells me I'm crazy. I'm waiting for results to come back. I don't think I'm crazy here. He looks at it, all the MRIs, he goes through them, and he said, you're not crazy, Susan. He said, you are lit up everywhere. It's all over your body. You could see cysts on my ovary. Everything was lit up. And he said, I guarantee you, you had that big tear to start with. And that second tear they did when they injected you. And nothing stayed in where it's supposed to stay in a joint. He said it's like, and it's still all there. He's like, I think it's still there. You didn't get rid of it. And I said, I wish I could hug you. He's like, come here. And he gave me this hug and I'm just crying. As he's telling me this, my doctor calls me. This was up in Helena, Montana. I lived down towards Butte. And she said, where are you? I need you to come up and see me. I said, I'm in Helena seeing Buzz. And she said, you need to come over to the office now. I went over there and she said, you still, now remember, this is like 3 weeks to a month later. She said, you have more than 2.5 times the safe amount of gadolinium. And from what I've read, and I'll ask you this question as we go, also, Dr. Semelka, is there really any safe levels of gadolinium? But I had 2.5 times the safe limit still in my body, which they said would be, quote, peed out. And then she said I had the gadolinium was all the way at the end of the chart. She said, I have never seen this in anybody. So she said, we're going to call the lab. So she put the lab on speaker, doctor's data. And the first thing the lab person asks is, have you been eating organic kale from California? I'm like, yeah, for a month every day. And she said, you've got acute thallium poisoning. So on top of the gadolinium poisoning, I had the thallium because thallium is a cruciferous vegetable. Oh yeah, broccoli likes it too, but they have an affinity, especially the kale, for pulling this deadly thallium, which is in rat poisoning, out of the soil. And because of fracking and other things, it should be down lower in the soil, but it's been coming up more. So long story short, everything was validated. We ended up doing, not IV because I was too afraid to do anything hardcore because I didn't know, again, genetically, THFR, that affects detoxification, genetically prone to low glutathione function. And I've tested after that, and I've had very, very low levels, which is your master antioxidant. I was just a hot mess. I was stressed to the max, wasn't sleeping, lifestyle, like all of these things were in here. And I was just a mess. So we had to start with the gadolinium. And I think at the time we used calcium EDTA because really no one knew what the hell to do. She's trying to research, this naturopath, trying to figure things out. And then for the thallium, you have to get a special approval to use this. The only thing that chelates that is called radiogardase or Prussian blue. $900 for a 1-month supply. So I had to do them like one after the other, very specific protocols. But I will tell you, I was so crazy that within just the first week of the gadolinium chelation, I started to sleep. My pain started to come down. I still have pictures where you could see through my hair. I was starting to look like a crypt keeper. It was, and again, my skin has never recovered, especially in the leg areas. I lost so much lean muscle that I forced the orthopedic to make me go to physical therapy because I couldn't walk. And he thought I was crazy then. And he said, you don't need physical therapy. He said, for what? And I said, so I can walk again. When I went to see my PT, who I've been with for 10 years, he said, Susan, I've never seen anything like this. And he said, it looks like you had surgery on that leg and haven't used it in like 6 months. Everything completely, what's the word I'm looking for?
Atrophy.
All the muscle, atrophied. When I would hold up and go like this, it was like a string. My leg, there was a absolute difference between the left leg and the right leg that you could see in the circumference. And then I had developed bursitis in the hip from having to stick my leg out to the side for so long, and my low back. So that's my gadolinium story. And I looked at lawsuits coming out then, and nobody would touch me because they said they'll just say it's Lyme disease. So I had no recourse to follow. It was so much money out of my pocket and so much time and pain that I've never experienced pain like that in my life. And that's my story. And I would love for you to take it from here with increased risk and start off with actually like, what is gadolinium, or any comments you
Right.
have in my story that may people. So
Sure.
the floor
Sure.
is yours, sir.
So your story really reflects, although there's interesting nuance to it, which maybe I'll touch on slightly, but your story actually is all of it is a standard story I hear from patients when they come. And in fact, most often one of the first things they say when they see me is, "You're the first person who believed me." And it's interesting. I think even there, I think Kate could also weigh in on this later. Even that, I think, has some placebo effect. To know that you are seeing somebody who the first time believed you. And to be honest, I've been shocked with the stories I hear about physicians chasing patients out of their office and being very rude to them.
Oh my God.
I completely unconscionable. And it's shocking and it's embarrassing to me as a physician that people would act that way. But let's maybe start with talking about the larger picture of gadolinium, what GDD is, gadolinium deposition disease, GDD is, and treatment. And also, I like to talk about now, so to provide even new information that people who've listened to prior podcasts wouldn't have heard me talk about before. So we'll talk about some new stuff as well. So let's begin with it. Gadolinium is a heavy metal that is used in MR imaging. So in the US, there's approximately 60 million MRs done a year. The number done with gadolinium is in the range of 20 to 30 million. Now, my estimate of people who acquire gadolinium deposition disease, or I'm say GDD, right? GDD is about 1 in 10,000. In some ways, in the past, I've been able to excuse physicians who they may not have seen other patients like this before. So it's difficult for me to figure out how much is just lack of being current in your education, how much is frank gaslighting. It probably depends on the individual physician, but what I do consider, now having written on this subject in major journals for 8 years, it is, I hate to say it, but it's probably a breach of standard of care if you do not know what this is when you have a patient who presents like you do. Because of all the heavy metals, to be honest, this is maybe the most obvious. And this is how it basically goes, is that the majority of people, they get a gadolinium enhanced MRI, and then anywhere from immediately to within a few weeks, but most of them are within a day, start getting symptoms. And you describe most of the symptoms that are the most typical that people should watch for. So the typical symptoms, now I will say, since gadolinium has gone everywhere in your body, it basically can cause any symptom. But the most common symptoms that people get are brain fog, cognitive impairment. They're just, and it's for the brain fog, interestingly, that is perhaps the most common reason that people find they can no longer work in their job, because they have complete cognitive impairment. So that's a very common finding. Intense skin pain is very common, as you described. Muscle twitching or muscle fasciculation is exceedingly common. Then, now you had it injected into a joint, but you also described on your other leg having bone pain. So the pain in bones is sort of like when you say, I play tennis and my knees are sore at times. Now, the pain that people get that's been described to me, it's like taking a screwdriver and jamming it into your bones. Now, a unique pattern of, although it can affect generally all the major bones, can get symptoms from it. very unique for gadolinium compared to many other entities, is that people get rib pain. And why rib pain is because in adults, most of the red marrow, which is the marrow that generates all the blood cells, including the blood cells of the immune system, which is what gadolinium has excited, is produced in ribs and central skeleton. So it makes sense if the cells that are reacting to it are made in the ribs, they're going to react because gadolinium is going to the ribs as it's going to everywhere else. So those are the most common symptoms, but people will have all sorts of GI issues, and a common one is just a hypotonic bowel. It's just not moving. Your bowels aren't moving. And again, gadolinium can insert in perhaps 100 different biochemical actions in your body. So that's also, when I get back to treatment, why the most logical treatment is to get at the source, the root cause, is if there's any disease that you can actually remove the entity, that's the best treatment possible. Everything else is, but if you can actually remove the entity, and that, if you like, as awful as the disease is the beauty of gadolinium and a number of the other metals. What we do is using the chelator DTPA. It's the most effective way to remove gadolinium and lead from your body. So, for instance, if I had either gadolinium or lead, I would get DTPA. It's the best technique. And I would do it the way we do it as well, which I'll get to in a minute. But your case is unique insofar as you had when I say unique, it's not unique, it's more uncommon. Most people get intravenous injections and get GDD. And usually an intravenous injection, the amount of gadolinium that's given to them is in the range of 10 to 20 mLs. Now, what you had done is an MR arthrogram. Usually, and they may have given you more, but usually an MR arthrogram has about 2 mLs of gadolinium. So there are many people who would say it's impossible for gadolinium because so many people have gotten it. I've given it to hundreds of patients. Nobody ever complained about it. It can't happen. Some people could say with 20 mLs, maybe you can get sick from it intravenously. But the fact that you're going to get sick from it, now you may have had more, but I've had a number of people with just 1 ml of gadolinium injected into their joint, hip very common, and they will get severe GDD as you have done. And that knowledge informed me that really what we're dealing with here is a disease which is immunogenic and toxic. Because if you think about it, if a vaccine, you can inject 1 ml of a vaccine, and for most people, it helps develop an immune reaction that may lessen the ability to get an injury. But as you're well aware, and again, the numbers range from 1 in 10,000 to maybe 1 in a million, where you can get really catastrophic reactions. But that's from 1 ml. You go, well, 1 ml. It's because you have stimulated your immune system, and the immune system then goes everywhere. So as I see it with gadolinium toxicity, what has happened is basically an immunologic reaction, then followed by the immunological reaction has allowed for all the toxic things that a toxic metal can do. Because it is also fascinating, and that's why I've said now for years, if you were really interested in figuring out about diseases, this is an obvious one. Because people with gadolinium deposition disease, you know that they have it. It's not like the other metals where was I exposed to too much lead and water and so on? You don't know. With gadolinium, you had the injection and now you're sick. There's no question about it. So it's an obvious thing. So the question is, what's different between you and between me? Because I've received 15 gadolinium injections. Now, ironically,
I heard that on that podcast.
All of this before I knew about GDD. So you don't think I'm like crazy. And the other thing I did it in a Louis Pasteur way, looking at new agents just to make sure that it didn't have the capacity to make people sick, or to do new styles of MR study to see how tolerable it was and how good the images were. So I thought, why should I experiment on somebody else? Gadolinium is so safe, I'll do it on myself. So in fact, some days when I was looking at which of these causes more vomiting, because that was a big issue in the MR gadolinium world, we don't want to use an agent that causes more vomiting. So I didn't believe any of that. I thought it was all marketing. So I would have given myself certainly two different agents blind on some days. And I think even one day I had three different agents. So can you imagine
No.
the amount of gadolinium? Now, the good news, number one, I don't have the disease. But number two, now I'm a perfect example of gadolinium storage condition, which is having a whole lot of gadolinium in me and not being sick from it. So I've used myself as a normal. You may or may not have seen we've written 3 papers on cytokine release in gadolinium deposition disease patients and gadolinium storage condition, which I'll call GSC patients. And what was interesting, since I have so much gadolinium in me, the total amount of cytokines of me compared to people like you who I otherwise had, or people who had severe gadolinium GDD from one injection, my total cytokines dwarfed all of the others, which again is also fascinating to think about that. And that's because there's different types of cytokines. Only some of them are pro-inflammatory, and we call that group the T cells that release some T effector T cells. And some of them are immune suppressing. So those are called T regulatory lymphocytes. So in my case, almost all of the cytokines would be suppressing inflammation. Someone like yourself, almost all of them are to incite inflammation. So the question is, what is the difference? Now, that's why also at this point in time, I'm actually, and this is what was interesting, Susan, with your both of your involvement in the epigenetics. So I'm actually looking at the epigenetics right now. Is there something about these people that makes them different? Now, the other thing I want to get to in this, before I do, I just have to, because I know that the two of you enjoy some humor. So in your presentations, you like some lightheartedness. But what drives me crazy, and still to this day, what drives me crazy, a physician saying that you come into the office, you're deathly sick, you have these symptoms. You have burning skin pain, bone pain, muscle twitching. And they say, well, everything I've read about gadolinium, if your kidneys are normal, you should be fine. It can't be. Maybe you need to see a psychiatrist, which is very common. I have some people actually been admitted to in some sort of Shutter Island way into psych ward. I mean, it's like you'd think we were in the 19th century. But the thing that I like to say, if you told like a 10-year-old child, this is what happened. You got something, and within that day, you suddenly had all these different symptoms that you never had before and were very sick. Was it something completely different and separate, lupus or like ALS? Or do you think it's what you just got? Do you think that's what did it? I mean, it is so painfully obvious. To not realize that is, I cannot, at this point in time, I don't actually accept that. I do not accept that you're practicing appropriate medicine if you don't understand that. It just is absurd. And then the other thing that's critical is that management has to be the optimal management, which I'll get to in a minute. But the other thing I wanted to address about in your story is something that now I've focused on more and more, and that is the concept of immune system dysregulation. And the most recent thing I'm focused on is what is the cause of it and what is the effect. So the things that you may think are the cause may be the effect. And what you want to address really is the cause. And sometimes you're not sure. And in those cases, I now look to treat both causes or more than one cause if I think that other cause is currently active. So you talked about Lyme. Mold is very common. And many people complain of having mast cell activation syndrome. I'm not sure how much of that MCAS is actually effect rather than cause. But
I think
the point
effect.
is, the point was, I'm actually assembling a chart to publish looking at all the different potential entry points of immune system dysregulation and counting up the numbers of people. And I realized, oh, hey, as I count up all these numbers of everything from mold, from Lyme, from CAS, and so on and so forth, autoimmune diseases, I end up with 200 million people. And you realize maybe all of us have some level of immune system dysregulation. And if you think about it, there's all these new toxins that we're dealing with, all of us are dealing with. All of our immune systems are dealing with PFASs, we're dealing with microplastics, we're dealing with glyphosates. We are all dealing with that. So the other thing that I like to tell people, imagine that all of these different insults that your immune system is dealing with, it's that, I don't know if it's a magician or what you would call the person who spins plates, and they can spin plates on like pool cubes, and they can spin 10 or so plates and so on, go back and forth, spinning your plates. That's what your immune system is doing. It's spinning like all of us. All of our immune systems are spinning 10 plates at least, right? At least 10 plates. So you think, okay, how many can we take before it all breaks down? So for many people, the end plate that brings everything down is gadolinium. So if you think about it, our immune system we're expecting our immune system to handle at least 10 different insults, everything from chronic viruses to chronic other infections like parasites to various toxins. So all of our immune systems are spinning at least 10 plates. So you have to think, at what point have we exceeded the number of plates that our immune system can spin and it all falls down? And I think that's what most of the people who have any of these sort of very severe immune system dysregulatory conditions has happened. They no longer, some people may only be able to spin 4 plates, other people 20 plates, but at some point you can no longer keep spinning the plates. So what I wanted to then get to is the next point of how we treat gadolinium, which happens also to be the same treatment as lead. And an important realization that you have to have is you want to reduce your total body content of the heavy metal. And as I said before, the beauty of heavy metals, as horrible as they are, and at least the ones that we have very effective chelators for, is that they can be removed. And removal is always the best treatment. Of course, the best initial treatment is avoidance. But if you have something, removal is straightforward. Detoxification is variable for different things and somewhat unpredictable. Removal is not. Removal, you want to have the most stable chelator to the metal. So I like one of the analogies I've used. It's like those games that you used to have in arcades and maybe in grocery stores of a magnetic crane that it lowers the little magnet thing that you get like a little nice plastic ring or a little stuffed animal, and you try to pull it up and then drop it into the chute to get it right. And it was great as a child. But that's all based on the strength of the magnet. So to use the analogy with a chelator and the heavy metal, basically you want to keep the chelator which is a very powerful magnet to whatever the thing is that you're picking up, so that it will hold on to it tightly, hold on to it till you drop it off. If you use a weak chelator, what will happen, and that's what would frustrate us trying to play that game, is we pick it up and then let it go right away. So that's why you want to use the strongest available chelator, because if it releases it right away, if it picks it up from skin, which is the second largest reservoir after bone, then if it releases it right away, there's a good chance it will go to your brain, right? Or other soft tissues, which you don't want to have happen. So you really want to use the best chelator for the metal in question, and different chelators are effective for other heavy metals. And I think it's still, the whole field is a work in progress. And I think because many people have thought that many physicians have thought it was some form of quackery, or what physicians will also pass off as, I think, the freedom, what is it called? Freedom health movement or freedom medical movement, of ideas that are not founded on science. But I would say that this is the exact mirror reflection of everything we do with gadolinium enhancement to begin with. So, and that's what I couldn't understand for the longest time, why people who did chelation didn't understand this. But with MR contrast agents, the whole focus has been on more stable agents. So the more stable it is, the less likely gadolinium will come off the molecule. So this has been my focus, to have the most stable chelator, because I don't want the gadolinium to break off and then get re-released in the circulation, which we call redistribution. So I want it to pick it up and then take it to the kidneys, and then it gets eliminated. So DTP right now is the most stable. So I use that all the time. And what we also expect, if you're sick from gadolinium, and not just whatever, sick from Lyme disease, for example, then if we pick up the gadolinium from your tissues, because again, it's everywhere in your body, and everywhere it is, there are T cells lined up looking at it, ready to react. So if you are actually sick from the disease, if you pull it back into the blood supply, you're going to react to it. For instance, I have had 4 chelations, and unlike with patients where I give them steroids and carefully and split it up with normal saline and so on. For me, because I wanted to see if I would flare to remove, and that's what we call, if you pull it into the circulation, your immune system suddenly sees lots of gadolinium blood supply, so it freaks out and releases a lot of pro-inflammatory cytokines, and people get flare. So if you're not sick from it, then you shouldn't get any flare. So I don't get any flare. But the initial period, which is the first 5 days, quite often it's right away, but it may start 2 days later, you get a gadolinium removal flare. And that is that your immune cells are reacting to gadolinium now moving in the blood circulation, right? So we control that by giving people steroids and antihistamines, and that it does a good job with the flare. The other thing that I found is critical, that I knew from very early on, you have to tell people what to expect. So you have to say, you have to get a flare. Now we manage it. There's a number of, you can imagine it's nuanced what we do. It's a number of things that we do to keep it down, but you have to have a flare. And this is the good news. You have to have a flare. If you do not have a flare, every other option of what you could have is far worse. So you actually want to have a flare. The flare in this case is your friend, but we control it. And whereas early on it was a very set regimen I did, now it's an interplay between the individual and myself. And all along the way, it's an interplay. They tell me when they think they can stop. I tell them, listen, I want you to stop chelation when you feel about 80% back to yourself, because we want to allow your immune system to recover the rest of the way. So, for instance, Susan, your case you described, you had a gadolinium enhancement before, which you didn't react to. So we know that
one was IV and another was in an arthrogram in my hand. So that was my third that tipped my plate.
Did not react to. So that also informs me that fundamentally your immune system can recover from it. It's you recovered from it before, to the point that you didn't actually even experience any symptoms. Now you retain gadolinium. We all retain gadolinium that are injected in us. You retain gadolinium from before, but you didn't react to it. So that tells me that there's a good chance that you'll do well with chelation, and there won't be very many chelations to get you better. I tell them, listen, when you're about 80% better, we'll stop and pause and see how you do. And I expect you will experience a re-equilibration flare, which I'll get to in just a second, at about 3 weeks, that is normal as well. But if it stays low and manageable and so on, let's just wait and see if you can just recover all the way on your own. So since I introduced it, what is a re-equilibration flare? ETPA has a very tight affinity, bonds very tightly with gadolinium, and I think with the entire gadolinium agent itself, if it's still in your body. It binds to it tightly. So that explains to us the gadolinium removal flare. But we take out of soft tissues where the gadolinium is much more accessible, because you can think soft tissues that should be easier to remove than bone. And bone's very hard. Well, it's tough to get out of bone, and you'd be right. It's very difficult to get out of bone. So although DTPA can remove a little bit of gadolinium out of bone, it doesn't remove a lot. So you say, you told me that you want to reduce the total body content. Yes, I do. So how I do that is by having a period of 3 to 4 weeks to allow gadolinium to move from bone back to soft tissue to re-equilibrate. And that principle is called Le Chatelier's principle. And with my hands, I'm just going to illustrate. I'll see if you can. Okay. So if here is the balance between soft tissues and bone, okay, then with chelation, we've taken now the gadolinium out of soft tissues, but bone is up here. So by Le Chatelier's principle, everything strives for equilibrium. Gadolinium will move from bone back to soft tissue like that. And then we want to repeat it again, moving it from soft tissue, bone re-equilibrates. So that's why at a minimum, you need 5 chelations. And that's also true for lead. And that's what, with people who lead drive me crazy. They say, well, we just need to do 1 chelation and it's fine. No, it's not. You need to be able to get it out of the bone. It's not enough to just temporarily get it out of the soft tissues. So you need to employ that Le Chatelier's principle. Now, it may differ for other metals. Their largest reservoir may be fat. So there's slightly different considerations, although fat wouldn't bind as tightly as bone, but you'd still want, and that's why we have multiple chelation sessions, because we want to gradually remove it out of bone back to soft tissue where we can get more of it out. So that's a very critical thing to understand. Now, also not surprisingly, if gadolinium is moving from bone, and again, gadolinium now is in motion, and you have T cells along bone, T cells along soft tissues. Now it's coming out of bone, going to soft tissues. You're gonna have symptoms again. That's called re-equilibration. And in fact, I think that re-equilibration flare is the most distinctive, because in some ways you could imagine a lot of people just react to any sort of IV, even if it's not a chelator. Is it a GAD removal flare, or is it just acting badly to the IV? But there's no way to explain re-equilibration at 3 weeks other than that you're reacting to gadolinium moving from bone back to soft tissue. And by the way, of course, it's not going directly from bone to soft tissues. It's also going through the circulation. So you're setting up a system where there's always some gadolinium coming out also of your kidneys. So it's very effective. People with relatively simple gadolinium toxicity, they do well. Now, another new concept that I'm mentioning for the first time here is that a number of people, since they are not correctly diagnosed, will try all kinds of different things to try to get better. Like yourself, Susan, at the time you're at, you had no idea. Nobody knew what was going on. They were telling you whatever, nothing. It's in your head. So a lot of people, and you understand it, they will try whatever to get better. And some of them may be nutty things that they hear online. And this is the problem, is that, again, if you think about it, there's 100 different biochemical reactions that gadolinium is doing. Now, DTPA just does this. This is all it's doing, is it is a cation exchange chelator, which means it's exchanging calcium or zinc that it's administered as being bound to. It's exchanging it for gadolinium and exchanging it for lead, to a variable extent, other heavy metals. Calcium will also pull out some of your native metals, zinc won't. But the point is, all it's doing is exchanging. you're injecting it in its active form. It's exchanging, we'll say, calcium for gadolinium, calcium for lead. Then those metals are being eliminated, and it's also eliminated in its active form through the kidneys. So there's nothing else going on. There's no changing of dopamine or serotonin levels or no GLP-1 activity, nothing. It's just a pure exchange of one positive charged atom for another positive charge. So from that point of view, it's also simple to grab the concept. So all it's doing is removing gadolinium from everywhere in your body. So that's what makes it a very ideal treatment. It's not doing anything else. It's just removing cations. So the problem, though, is that people can also get much more complex than you as far as that sort of, whereas every one of us has at least a walnut-sized immune system dysregulation in our body. There are some people who have those B horror film, where there's some alien, which is some growing blob-like thing.
Big blob.
People have these huge blobs of immune system dysregulation. Now, those can be a big problem. And the point is that very early on, I thought removing gadolinium will cure everything. And certainly the other thing that we do using steroids and antihistamines helps most other things too, because the treatment for many autoimmune diseases is steroids. And for MCAS, we're treating for MCAS as we're removing gadolinium. As it turns out, we're using that techniques. But in about 1% of people, they have some strange immune dysregulation that this does not help. Now, it's very rare. Now, I have not personally seen it, so there is the caveat that maybe chelation wasn't done properly. At a distance, though, I have heard of people like that. Now, quite often it may be that they haven't done enough chelation. Some people just simply have stored more gadolinium or more sensitive to gadolinium, so you need more chelations. But the category that I was bringing out for the first time here is that since there's 100 different biochemical steps, probably at least, that it's interfering with, if you've done, and your immune system is now thrown off, it's not acting normally. So anything that you get, it may or may not act normally. So if you get a vaccine for whatever, it may not be doing what the vaccine is doing for 9,999 people out of 10,000. It may be doing something else. So the thing is that, okay, what happens if you changed those biochemical steps that gadolinium has done? Now it's a different set. Now you've changed it because you've done some other treatment that's thrown off your immune system. So now you have what I call morphed GDD. And that is now the latest thing that I'm thinking about, what to do with people with morphed GDD. Now, people who are in serious trouble with morphed GDD, thankfully, are very rare. But I think what distinguishes me from maybe most people, most physicians, I want to figure out what it is, and I want to help them too. I don't accept, hey, 1 in 10,000 people get sick from gadolinium. Well, that's okay. I just have to say something else that drives me crazy about physicians denying that gadolinium deposition disease exists, is that all of the very expensive DMARD drugs that are used for ulcerative colitis and Crohn's, like Humira, like Ozempic, like Stelara, if you listen to the entire commercial, they say, don't take whatever it is, Humira, if you're allergic to it. And you have to think to yourself, how do I know and I'm allergic to Humira? Did I just wake up morning and think, God, I really think I must be allergic to this drug I've never had before? No, the way you know you're allergic to it is you had it and you reacted badly to it, right?
Yeah.
If you can react to a peanut, and a peanut can kill people, and you've eaten it, so you're dealing with 5 layers of your immune system that can, deal with allergens. You're mainlining it. You're injecting it into a vein, which your body and your ancestors for 1 million years have never experienced anything like it. It's always been either on the skin or breathing or through the GI tract, but mainlining it right into a vein is perfectly unique for the last 100 years. And we expect everybody will be doing fine with that. I mean, all of these things are absurd. And again, if you react to gadolinium, hey, you react to gadolinium, and guess what? The treatment is don't ever get it again. And many people are probably in a situation that you would have been, Susan, and I bet you that you may have had very mild symptoms that you didn't really recognize at the time, and maybe thought, it's my hip is bothering me, and maybe I did more exercise than before. But if you were attuned to it, and muscle twitch, you think maybe I just did too much exercise or whatever. If you were attuned to it and you didn't have another gadolinium injection after that, you would be perfectly fine. So my focus now is that you have to recognize GDD when it first presents, because fully a third of people, will recover on their own and won't need any chelation or whatever. You were one such person with the first gadolinium injection. That if you were instructed that this could happen, you were aware of the symptoms, and you had them, and you were fortunate enough to recover from it, then the treatment is never have another gadolinium enhancement study again, and you'll be fine. So I want to tackle that group to begin with, because that right away would eliminate maybe 75% of the patients, and certainly the majority of people who are very sick. This is what frustrates me, is that patients will get multiple gadolinium injections, and each gadolinium injection you get progressively sicker and sicker. With each one, you get sicker. And that to me is horrific, because I'll have patients who've had 50 gadolinium injections. And the point is, it's like at that point, it's like somebody with advanced cancer. It's like coming in with stage 4 cancer, with metastases everywhere. Am I going to be able to treat it? Yeah, because the problem is, if we use my formula, which is for every gadolinium injection, it's probably 5 chelations. That's 250,000. That's 250 chelation sessions, and we charge $1,000 for a 2-day chelation. So that's $250,000, and staggered over a course of every 3 weeks, which is then years. And who can afford that? Almost nobody can afford.
Question: so, you have the right to refuse the contrast, though. Can't it? Like, I will never ever. I don't mind doing an MRI, but I tell people you can refuse. Now, I had read, and this was again years ago, that there was a vegetable dye that was non-toxic. Is that truth, or is that an old wives' tale? But I know that you can refuse the contrast, and they'll tell you we won't be able to see everything as well. Do you want to take that chance? Because that's what Kate and I were talking about earlier. Do you want to play that Russian roulette, or do you have it's medical.
And a number of people, as you can imagine, email me with these questions about themselves. I generally will say, if you're not really sick from anything, then the chances are relatively low, but you have to also, and that's a problem that people don't have, and radiologists don't necessarily tell them, what is the potential benefit for getting the gadolinium? Is this critical for my study, or is it just nice to have it? And I don't know anybody other than myself at this point who's prepared to answer that question. And you do, and that's the other thing, you're right. You have the right to refuse, but as you probably are also aware, it's not unusual then for physicians to say, well, I'm not going to do the study if you're not going to get gadolinium. So my view is this: you say, I'm really worried about that I might develop toxicity. It's a known, particularly since one of the largest groups. First of all, who most likely gets it? I'm looking at 2 people who are most likely to get it. White women between the ages of 20 to 60 are most likely to get GDD. Then you add in additional factors. So the factors you add in is something else that is immune system dysregulator. Lyme disease, mold toxicity. A very common thing is multiple chemical sensitivity syndrome. And you think if somebody's sensitive to a whole bunch of chemicals, and they say they're sensitive to everything, what are the chances they're going to be sensitive to this chemical? And at this point, still, you have to advocate for yourself. I also tell people if they're not going to do the MR on you, then you go somewhere else. There has to be rational MR system somewhere.
Yes. I have a question about this. Is this
global in the way that gadolinium is used, or is it similar to the way that food is with the FDA, where we have different standards for different countries? Because I feel like in some ways the European FDA standards are a little bit more thoughtful in ways and protect some of their citizens from things that our FDA does not protect us from. And I wonder, do you see the same level of gadolinium poisoning in other countries?
Well, that's actually an excellent question that you brought up, and specifically regarding this. So the European Medicines Agency, they disallowed the use of linear gadolinium contrast agents. I don't know, maybe it's 5 years ago or longer than that. So, but the US, it's still allowed to use linear agents. So that's a perfect example of where they're more strict and more logical than the FDA has been.
Yeah. And
Yes.
I think what you spoke to before about how physicians tend to call it quackery if they don't understand it. Susan and I have talked about this in another recent episode with Marek, where we were talking about Eastern energy medicine, that sometimes the things that science doesn't understand yet will be the future of science. And we call it now magic or quackery or whatever you woo woo, whatever you want to call it. But ultimately, that's our future of science that we just haven't come to yet. And so the dismissiveness of people's symptoms. And Susan, as you're talking about your story, I just feel such a depth of compassion for you to be told that you're crazy, that you're making things up, that you're not being believed, because the psychosomatic response to not feeling understood and believed for what's happening in your own experience,
Awful.
it compounds your suffering to such a degree that we know in psychosomatic studies that we develop very real symptoms in response to stress. And so if you already have a very real symptom happening from the gadolinium poisoning, and then on top of it, you're having subsequent stressors that are creating further anxiety, further inflammation, then you start to have kind of a Rubik's Cube of an issue that you don't know how to define anymore because it's so further compounded by all of these extraneous factors. So I'm really
Yeah.
sorry to hear that that happened to you like that. And the misuse of anxiety, just to throw anxiety at a patient who seems
Mhm.
worried about something, is such an inappropriate and unethical use of that diagnosis that I think I'm just so sorry to hear it. And my heart really goes out to you.
Thank you. And Dr. Semelka, I know you had mentioned on the other podcast where I'd heard you about lifestyle. And this is what we tout here is everything comes down to lifestyle. Even if you do all the chelation, you think you're feeling better, but you go back to a crappy lifestyle that likely compromised your immune system to begin with, it doesn't matter, right? You're
Right.
going to have a harder time. The majority of people I meet or would see me would have no idea that my body has been through what it's been through. And I just say it comes down to my commitment to wanting a quality of life. That like 6 weeks, there was no quality of life. And that really made me see that if I can't live the way I want to live, why are we here? So that's the commitment to myself of why I'm stringent with how I eat and how I train and the joy I want in my life, because that's the quality. And otherwise, we're here
Right.
just to thing. So you can go back to doing all those things that contributed your body to not be able to work with these toxins that come in, including the gadolinium. So I'm going to reduce my risk by never getting another one again, but I'm going to keep working with my body to make it stronger. And so if you want to go back to eating the crap and sitting on the couch and playing on your phone and not moving your body and drinking the alcohol, then that's those plates that are spinning and it's putting you one closer to the crash. Am I right?
Yeah, it's funny because that's exactly the approach that I use with patients. And in fact, even, and Kate may appreciate, even the way I treat them, first of all, being very personable and telling, I, you're at the right place. I know what you're saying is correct. But I have most of the time when I chelate patients, and it depends on the individual, because most of them have been isolated by their disease, including the doctors telling them and their family that they can't be sick from gadolinium. They feel isolated. Their family doesn't believe them because the doctor said it couldn't be and so on. So they're very isolated and they think it's only me. So what I do is I have a treatment room that has 6 chairs in it, and I describe it. Think of it like you're being treated in Dr. Semelka's living room. So it doesn't look sterile. It's comfortable chairs, 6 people sitting around, and they're talking to each other. They're talking to new people who are coming and saying, "Oh, don't worry about the flares. I have the flares and it's fine." So I think that alone, I think, for instance, coming to see the world expert and being believed, number one, that's a 10% health benefit right there. Then being an environment where you're together with other people with the same stories and they're pleasant and talking about stuff and talking about also things that have worked for them and so on. That right there, even not doing anything else, is another 10% of getting them better. So then the chelation comes in. But you're 100% correct, Susan. That's what I do too. I tell them, listen, you now have an immune system dysregulation, and you're going to have it to other things. A lot of people now are allergic to things they never were before. Now they can't wear nickel jewelry. I said, you have to be now careful of your health, which you've never had to do before. You have to eat better, to think of your microbiome. And I tell them my opinion of how I would manage the microbiome. And I tell them the good news in all of this, before you may be eating terrible food and living a horrible lifestyle, now you have to eat well. You have to maintain some level of exercise, and not too much. It has to be in the Goldilocks range, not too little, not too much, but just the right amount of exercise. And guess what? I mean, the silver lining in this is you'll probably live longer and better because you've had to.
Oh,
Because you've had to. Now, this applies to the people. Fortunately, many of them are, relatively straightforward and do fairly well fairly quickly, but they then have to change their lifestyle. But there are these other problem groups that I've talked about but it breaks my
I'm not
heart.
going to change.
And I guess the other thing, and maybe both of you find this in how you do your practices, that I find disappointing with physicians. One of the things is I think that in the modern age, a lot of groups, you can only spend 10 minutes with a patient. And once they start talking about muscle fasciculations and I think you need to see a psychiatrist, right? The time crunch of not having enough time. And I'm of the opinion of what makes a good healthcare provider is somebody who knows the disease that they're dealing with, the category of diseases, and spends time listening to the patient. Doesn't matter if they're an MD or a nurse practitioner or professor at Harvard, the disease process, and you spend time with the patient, you are then an excellent provider of health. So it's funny how far I've come from many MDs. I think traditionally I was no different than the majority, having a very strict allopathic view to things, and a lot of things maybe Eastern medicine, so on, as accurate. But it's interesting now that I've gotten into the depth of this disease, I'm open to just about everything. And especially if it's working for you, then go with it. And that's, I think, Kate's point, that there's a lot of things that we don't know and we don't teach it in medical school. And I think the critical thing is to be open-minded, and to be open-minded to, you come in, I've never heard of what you've ever said before. And yet you did say you had a gadolinium injection. I never heard about it. They could, everybody has a
There.
computer, they could look up online gadolinium toxicity, and they would find my name and see a whole bunch of peer-reviewed papers. So it's not, to me, it's inexcusable for what happened to you for the last 5 years. I would say is inexcusable. There's no reason. And yet, still to this day, I see patients who are blown off. They're close to 10 minutes. I don't know what you're saying. And I think men, and certainly I think female doctors as well, have a paternalistic approach. And even if they don't know something, they believe they know it. and they say what they believe as if they know it, but they don't know it. So again,
Yeah.
I hear a lot of things people tell me about a lot of things, for instance, with gadolinium, and saying this is not gadolinium, this is something else. This is some other disease. Maybe I'm sick from gadolinium, but these symptoms, it's something else. And I tell them, listen, gadolinium can basically do anything. There's the 5 classic things that we've talked about, maybe just to refresh the audience. There's the cognitive impairment, the brain fog, burning skin pain, muscle twitching, and the intense bone pain. I didn't mention before they get pins and needles, which is
Yep.
small fiber
I have that too.
neuropathy. That's very classic. But then they can get cardiac arrhythmias, they can get GI tract, very common to have vision issues, hearing issues, and they describe a certain type of headache, which they say it's not like headaches I've ever had. It's like, imagine that you are putting on a
Device.
swim cap, it's 4 sizes too small. That's what it feels like.
So I said it was
A
like a vice.
constriction on my head, and I've never had that before. So
Yep.
what I tell people, I don't know, you have these symptoms. I think they could all be gadolinium. I could be wrong, but let's do this. Let's do 10 chelations. Maybe it's fewer. And if at 10 chelations, something is untouched, then maybe we have to look, is there something else that isn't
Yeah.
gadolinium related? But I also find that gadolinium has a way of affecting everything else and making everything else worse. And that's one of the reasons also that I use steroids and antihistamines to treat other things as well. As I said, MCAS, we basically are doing an MCAS treatment. It works for mold. It works for most autoimmune diseases, what we're doing. So I basically think let's do a broad spectrum, but focusing on the gadolinium removal. And the other thing I want to say about this, Susan, it comes up quite often that people say, my doctor tells me I should detox first, my liver or pancreas or whatever, and then chelate afterwards. And I tell you what, we'll do it all at the same time. We'll do it all at the same time. I don't want you to, for sure,
Yep.
if you have gadolinium toxicity, you don't want to delay chelation. And there's no reason we can't do all these other things at the same time.
No, the body can handle all that. Yeah, that's what I did too. That's what I did too. This has been just fantastic information.
Thank you so much for this incredible information. I have learned so much today, and it's really beautiful to hear your expertise shine through on something that is so new to probably so many of our listeners, but perhaps will really hit home for some of them, or for people who know someone who's had an experience like this and been extremely invalidated for it and labeled as the mystery illness cause and bucket that people get put into when the physicians don't know what to do. It's so impressive how much you know about this. And I feel like we could probably continue talking for hours and just go into incredible rabbit holes with you.
I think a big thing here is creating awareness so that people aren't just going blindly into MRIs with contrast, but to understand that there are risks, even if you don't have kidney disease, if you are the white woman between those age ranges. And I think that's just super important, so that now it's in the back of your head and you have the information to make the best educated choice.
I would like to add to that, and then we can get to the end, is that I think there are a lot of people with this disease that are being mismanaged as having something else. So for instance, the symptoms are very similar to fibromyalgia, are basically the same. And my colleague thinks that you could actually call gadolinium-induced fibromyalgia this disease, because I'm not sure how many people with fibromyalgia actually have GDD. Similarly, the risk factors for fibromyalgia are heavy metals, and I'm thinking if it's not gadolinium, turns out everybody has lead in them. Everyone has lead in them. Is it lead induced fibromyalgia? So from my point of view, if you have some weird thing, and the problem is that even very high price doctors don't necessarily know current stuff at all, and they maybe are just good self-promoters and self-marketers. But if you have some weird disease and you're very sick, and again, it doesn't have to be GAD, it could be lead. And if you look at the list of things that lead causes, depression is high on the list. I would say I would get chelated if I had some weird disease. If I had, for instance, stiff person disease, I would get this to see if what is an untreatable managed condition isn't actually either gadolinium or lead or another heavy metal toxicity that can be removed. And the fact that physicians don't consider that for a number of people when they should, and that's why people have to take it onto themselves. I got something weird because it's not that expensive and it's fairly clear cut. If you're sick from gadolinium, lead, maybe also some of the other heavy metals, you're going to have a removal flare. You're going to feel a little bit better in week 2. Week 3, the symptoms are going to get worse again. That's telling you you have that metal toxicity, and the treatment is just more chelations, and you won't be cured, but you'll be near cured. And by changing your lifestyle, you'll live a longer life. And I tell people, listen, it's just going to be something like chicken pox or herpes. We will get cold sores maybe every few months if we're stressed. This will be something like that. And it'll be something you can even use it positively. If you're getting flaring, it's probably telling you you're too stressed, getting back to what Kate was saying earlier, where stress is a huge thing in this. Maybe you're too stressed. You're starting to get the muscle twitching again. It's an indicator to you to calm down. Whatever it is you're worried about, it's not that important. Your symptoms are telling you to calm down.
Listen to the body and allow this to be. I hear this so often from people who have life-threatening diseases or accidents where they say, this horrific thing was actually the greatest gift of my entire life because it inspired a new appreciation for life. It helped me take care of myself on a new level, cut out anything in life that detracts from what's in my highest good. And so if you're out there listening and you feel like you have gadolinium poisoning, this feels like a rabbit hole that you'd like to explore more, maybe consider that a year from now, some point in hindsight, you'll look back and potentially be thankful for this horrific experience. I don't know if you feel that way, Susan, if this has in some way been a gift in your life or not exactly.
Part of me feels like I used to feel like I was just so robbed because I'll never be where I was and I'm always going to have something. But again, creating that awareness to know that I'm never going to have another MRI and that I just need to dial my lifestyle in and look at me. I'm just a couple months away from 60 and my metrics, like everything, I'm feeling amazing. I'm performing amazing. I'm living the quality of life I want to live. And were all these things and helping other people. My story, that's the way I look at it. I had to go through all these things I've gone through to help other people. And if I can help one other person not have to go through what I went through or to not think that they're crazy, that this actually can happen, listen to the body, then it's all, that's why I'm here. And so we have our pluses and minuses. So I'm just grateful to be here. Like literally I say,
Yeah.
I'm grateful to be here. I survived as a police officer. I had some close calls. I've had a lot of close calls in life. I've had this, I had the Lyme, and I'm still here ticking, knock wood, and hopefully for a long time, and just show people that we still don't have to get worse as we age. No matter what you are dealing with, we can still improve with age. We can slow that aging process. Getting older doesn't mean we have to slow down no matter what we're dealing with. It all comes down to the choices that we make in our everyday life.
Yeah. And use your health concerns as inspirations for healing and moments that catalyze your growth rather than spirals into the doom and gloom place when really there's a lot more life to live, even with a diagnosis like this.
Absolutely.
Okay.
Ask them the question.
Our final question, Dr. Semelka. How are you in your personal life creating your own radiant life through epigenetics?
I have to laugh when I talk to patients about this. I hate to admit, one of the first things I tell them, you got to reduce your stress, whatever stressors you have. It's critical because those cytokines of stress, they're following the same pathway, the cytokines for GDD. So you got to reduce your stress. Then you have to eat healthier. You can no longer eat junk food, ultra processed food. You have to eat healthy food, and you have to do things that you enjoy. Get a pet. So if you're single, have a pet. Have a pet that you can share companionship with. So I tell them the problem is, in my case, I'm doing the exercise while I play tennis as much as I can, a couple times a week, and I try to eat better. And I think what I derive tremendous satisfaction from is that, I guess, as Susan describes her prior career, as a radiologist, as I was before, we basically never see patients, never see them. So that's why it also drives me crazy when radiologists say they've never seen the disease, because I think, well, hey, you never see any patients. So of course you're never going to see the disease. And I can say that because I was a high-end radiologist for many years. So I know I didn't see any patients. So I'm certain for sure you didn't. But now, I get the appreciation of these people come and see me, almost everyone, and they say that you have saved my life, which gives you an incredible sense of, and again, talking about eliciting positive energy and positive cytokines and so on. It's incredible to hear that. But I do have to say, the one bad thing is that it is actually very stressful having to oppose basically all of organized medicine. You think this is easy and you think I want to do this to oppose all of organized medicine? No. But the thing that I have that I'm certain both of you have, and I'd like to see more people do the same thing, I don't have to have something to fight against it. So I don't have to have GDD. When I have a patient come in and say that they got gadolinium and they got then a second one and they got worse each time and the doctors didn't know what they have and they don't want to see me anymore, I don't need to be that person to know that it is wrong. And that actually is one of the things that really motivates me, is a desire to change everything in this regard. And if it takes legal action in some cases, then so be it. Unfortunately, quite often that needs to happen in our society. But I just, when people come and tell me that and they're very sick, that motivates me to keep going, even though there are lots of radiologists in line saying it's crazy, doesn't know what he's doing. And I laugh because I do say I've written more on the use of gadolinium in humans in a positive way than anyone. So you're telling me I don't know what I'm doing? I know more about this than you and any other radiologist. So I'm speaking from a position of having built that box, but I'm now thinking outside that box that I built that you're still dwelling in.
Wow. Yeah, you're an incredible trailblazer in a world that really needs people to reassess what they think they know and build upon it with a beginner's mind, where they can add new research and new understanding so that we can evolve medicine and we can evolve science. And I do think that it takes people like yourself who are willing to carry that burden of meeting traditional medicine and challenging it. So thank you for doing that.
Thank you. Thank you for, and from coming from a GDD person, thank you for all you do for us to show that we're not nuts. Validate us, and that there is hope and there is treatment for it. So thank you. And we'll have everything in the show notes. You sent me your links, so we'll make sure if anybody wants to reach out to you, that it'll be in the show notes. And do you have a website you want to give?
That name is actually brings the person to my website. So my website is Semelka MD Consulting.
Richard Semelka, MD Consulting. Awesome. Yeah. So all of that will be in the show notes as well. So if you feel like you're suffering from this, please, please, please reach out. There is hope. And thank you so much again for sharing your time and your knowledge and your passion about this with us today. Thank you, everybody, for joining us. Please, please, please share this episode. You might save a life, literally. So thank you, everybody. Get out there, make it a great day, and be your most authentic selves. Thank you for joining us.
Thank you so much for tuning into our podcast.
If you enjoyed this week's episode, we'd love for you to share it, leave a review or comment, and subscribe wherever you listen to podcasts. Help us get this information out to everyone who could benefit, and we'll keep bringing you the content you crave.
You can also check out our podcast site at everydayepigenetics.co and sign up for our newsletter to stay updated on upcoming episodes. The link is in the show notes.
If you're interested in DNA or epigenetic coaching with Susan, or Radiant Life coaching for deep inner work with Kate, our contact info is in the show notes below.
Now go and make it a great day and let your most authentic self shine.